Hello, this is Dr. Cotty, and today we're going to discuss medications for psychotic disorders. Schizophrenia spectrum disorders are the main reason to administer antipsychotic medications. So schizophrenia usually has acute exacerbations with intervals of semi-remission in which the manifestations are present, so the signs and symptoms are present, but they're less severe. So medications are used to treat the positive symptoms, and if you recall, those can occur in behavior, thought, speech, and the negative symptoms like social withdrawal, lack of emotion, lack of energy, flattened affect, or decreased motivation or pleasure. The goals of psychopharmacological treatment for schizophrenia spectrum or psychotic disorders are to suppress acute episodes, prevent an acute recurrence, and maintain the highest possible level of functioning. So those are our goals for medication management. Generation what? So medications for psychotic disorders have two generations. First generation, which is also known as conventional, or second generation, which is also known as atypical. First generation or conventional antipsychotic medications are mainly used to control positive symptoms of psychotic disorders. If the individual can tolerate the adverse side effects. But if they're really violent or particularly aggressive, this might be the best medication choice for that person. Second generation or atypical antipsychotics are the current medication of choice. That's because they're more effective with fewer adverse side effects. So here are some advantages of atypical antipsychotic agents. They can relieve both positive and negative symptoms. They decrease affective findings like depression, anxiety, suicidal thoughts or behaviors. They can improve neurocognitive defects like poor memory. And they have fewer to no extrapyramidal symptoms, EPS, including tardive dyskinesia. That's because there's less dopamine blockade. There are fewer anticholinergic effects, with the exception of clozaril, which has a high incidence of anticholinergic effects. But most atypical antipsychotics cause little or no blockade of cholinergic receptors. And when there's less side effects, there's less relapse because patients are more likely to be compliant with the medication. So now let's look at a prototype of a first generation or conventional antipsychotic, Thorazine. So Thorazine has low potency. And if you'll look on this slide, you can see that there is an H or an M or an L next to the different antipsychotics, conventional antipsychotics, to say if they have high, medium, or low potency. But we're going to talk about Thorazine right now, which has low potency. The purpose of this medication is to block dopamine, D2, acetylcholine, histamine, and norepinephrine, NE, to block those receptors in the brain and periphery. It's used for the treatment of acute and chronic psychotic disorders, schizophrenia spectrum disorders, bipolar disorder, especially the manic phase, Tourette's, and sometimes to prevent nausea or vomiting. It prevents nausea or vomiting through blocking of dopamine in the chemoreceptor trigger zone of the medulla. I would say that's a less common use of this medication. So with these medications, there can be complications. Some clients are at risk for a granulocytosis, depending on which medication they are on. So we want to observe for indications of infection, like fever or sore throat. We also want to monitor the white blood cell count. Medication could have to be discontinued if the lab test indicates the presence of an infection. So if a fever or sore throat occur, we want to make sure that the patient notifies the provider. Anticholinergic effects may occur like dry mouth, blurred vision, photophobia, urinary hesitancy or retention, constipation, or tachycardia. So some strategies to decrease this would be to sip on water all day, maintaining a fluid intake of 2 to 3 liters, chew sugarless gum, wear sunglasses when outdoors. If you have the blurred vision, avoid things that are hazardous, eat foods high in fiber, and use the restroom prior to taking the medication. Extrapyramidal symptoms, or EPS. This can result in acute dystonia. That's severe spasm of the tongue, neck, face, or back. It's a crisis situation that requires rapid treatment. So we want to monitor for this. It could occur 5 hours to 5 days after the first dose of medication, and we would want to treat it with an anticholinergic agent like benztropine or cogentin or Benadryl. Parkinsonism, Parkinsonism. So manifestations could include bradykinesia, rigidity, the shuffling gait, drooling, tremors. So we want to observe for this the first month after we initiate the therapy. Again, we can treat this with benztropine, which is cogentin, Benadryl, or something called Symmetrol, which is less likely that we would use. Akathisia, inability to sit or stand, continued pacing, and agitation. We want to observe for akathisia for the first 2 months after we start treatment, and we manage this with beta blockers, benzodiazepines, or anticholinergic medications. If we don't treat the EPS symptoms, the individual may have tardive dyskinesia. This is late EPS. Involuntary movements of the tongue and face, like lip smacking, the tongue protruding out of the mouth, involuntary movements of arms, legs, and trunk. So we always want to keep the patients on the lowest dose possible so that this does not happen, and evaluate the client on a regular basis. This is after 12 months of therapy and then every 3 months. I think that we should evaluate the client more frequently than that personally, but definitely every 3 months. And manifestations may occur months to years after the initial therapy. If it occurs, the dosage may need to be lowered, or the person might need to be switched to an atypical agent. So complications of antipsychotics that are first-generation conventional antipsychotics, such as Thorazine, can include neuroendocrine issues. Gynecomastia is the development of breast tissue. Galactorrhea is milky discharge, and menstrual irregularities. So we would advise the client to look out for these symptoms and to tell their provider if they occur. NMS, or neuroleptic malignant syndrome. This is most common within the first 2 weeks of treatment, and if it happens, we want to stop the medication right away. So it can include a sudden high fever, blood pressure fluctuations, dysrhythmias, muscle rigidity, changes in LOC, level of consciousness, even up to a coma. This is very serious. They may need cooling blankets, antipyretics like aspirin or acetaminophen. We want to increase the client's fluid intake, and we would give them medications to induce muscle relaxation. Wait 2 weeks before resuming therapy and consider switching to an atypical agent. Orthostatic hypotension. The client should develop tolerance for this in 2 or 3 months, but we'd want to monitor the patient's blood pressure and heart rate for orthostatic changes. Hold the medication until the provider is notified of the change. So we'd want to notify the patient that this could happen and that they may feel lightheaded or dizzy when changing positions. So if this occurs, the client might want to lie or sit down. Orthostatic hypotension can be minimized by getting up or changing positions slowly. So here are more complications of antipsychotics that are first-generation conventional antipsychotics with the prototype Thorazine. So let's take a look at this. Sedation. We'll want to tell the patient that this could be less sedating in a few weeks, the medication, and that they should take it at night to avoid daytime sleepiness and not to drive until the sedation has subsided. Seizures, these are greatest in clients who already have an existing seizure disorder. So of course we would want to know if the individual had a seizure on the medication, and they may also need an anti-seizure medication increase. Severe dysrhythmias. We want to obtain a client's baseline EKG and potassium level prior to treatment and periodically throughout the treatment period. We also want to avoid concurrent use with other medications that prolong the QT interval. Sexual dysfunction is common in both males and females. So we'd want to tell the clients this. A lot of individuals feel uncomfortable talking about it. So you would say something like, sometimes this medication in a small percentage of people can cause you to have an inability to have an erection, or for men and women, the inability to have an orgasm. So if that occurs, just let me know. Individuals may also have skin complications such as photosensitivity or contact dermatitis. So make sure that we tell them to avoid excessive exposure to sunlight, use sunscreen, wear protective clothing, and to avoid direct contact with medication handling. So these medications are contraindicated in clients who are in a coma, who have severe depression, Parkinson's disease, prolactin-dependent cancer of the breast, or severe hypotension. Also, it's contraindicated to use this medication in patients who have dementia. And you have to use it with a lot of caution if your client has glaucoma, paralytic ileus, prostate enlargement, heart disorders, liver or kidney disease, or seizure disorders. Now let's discuss medication and food interactions for first generation or conventional antipsychotics. Anticholinergic agents, when taken with this medication, can increase side effects. So advise the patient to avoid over-the-counter medications like sleep aids that contain anticholinergic agents. Adding CNS depressants can increase CNS depressive effects when they're used with alcohol, opioids, antihistamines. So advise the client to avoid alcohol and other medications that cause CNS depression. Advise the client to avoid hazardous activities such as driving. Levodopa, by activating dopamine receptors, counteracts the effects of antipsychotic agents. So we'd want to avoid concurrent use of levodopa and other direct dopamine receptor agonists. Nursing administration. We want to make sure that we're using the Abnormal Involuntary Movement Scale, or AIMS scale, to screen for the presence of EPS. Assess the client to differentiate between EPS and worsening of a psychotic disorder, and administer anticholinergics, beta blockers, or benzodiazepines to control EPS. If symptoms are intolerable, they may need to be switched to a low potency or atypical antipsychotic agent. Advise the client that the antipsychotic medications do not cause addiction, and that they should take the medications as prescribed and on a regular schedule. So some individuals may stop the medication when they start to feel better. We want to advise them not to do that. Some therapeutic effects are not noticeable until 2 to 4 weeks after. Sometimes it's several months depending on the medication. But for these medications, usually you can tell in a few days. Consider an injection. Administering IM once every 2 to 4 weeks is often helpful for clients who have difficulty maintaining a medication regimen, so we can increase compliance with injections. Now let's talk about second-generation atypical antipsychotics. We're going to use risperidone or